Hello, my name is Dr. Michael Levy. I'm an associate professor of neurology at the Massachusetts General Hospital and Harvard Medical School in Boston, Massachusetts. It's a pleasure today to present to you a series of abstracts that were submitted to the American Academy of Neurology, the 2020 annual meeting. As you know, the 2020 annual meeting for the American Academy of Neurology was canceled related to the COVID pandemic, but the abstracts were accepted and were published in the journal Neurology. We culled a series of abstracts for you and will present the highlights today related to the disease neuromyelitis optica spectrum disorder. So what is NMOSD? Neuromyelitis optica spectrum disorder is an autoimmune disease. It targets the aquaporin 4 water channel. The inflammatory process causes relapses of the optic nerve and spinal cord, leading to blindness and paralysis, as well as bowel and bladder dysfunction. There are some unique clinical features of NMO that includes area postrema attacks that presents with persistent hiccuping, nausea, and vomiting. And NMO is also associated with symptoms of neurological damage in the spinal cord, leading to headaches, fatigue, pain, and sleep disorders. Commonly, NMO patients are misdiagnosed as MS. In 2012, that was as high as 30%. It's improved over time related to accessibility of the aquaporin 4 antibody test, which is the most specific way to distinguish NMO from MS. The treatment for NMOSD is immune suppressive therapy. There is a new FDA-approved drug, eculizumab, that was approved in June 2019, and there are several in development. We'll discuss several of those today. The 2020 annual meeting for the American Academy of Neurology was postponed. There will be an online version of several abstracts that will be available for viewing online. The abstracts will also be published in the journal Neurology. And like I said, we took several of the NMO-related abstracts, and we'll discuss them today. The first series of abstracts relates to distinguishing NMOSD from MS. This is critical because the treatments for MS that include things like Rebif and other beta interferons can be harmful in NMO patients. So you definitely want to get the diagnosis correct before you start them on treatment. In this first study, the authors looked at not making the diagnosis of NMO correctly, but making the diagnosis of MS correctly. What they found is that out of 319,000 patients in the health analytic database, those who were diagnosed with MS initially, about 2,000 of those were later reclassified as NMO in their diagnosis. And when they look back at their own cohort of patients, of those patients who met all of the criteria for MS, there were 54 patients. 4 of them tested positive for the aquaporin 4 antibody and were later changed to the diagnosis of NMO. And this got them thinking that maybe there were MS patients out there who were actually NMO patients, misdiagnosed as MS. And because there are no specific serological criteria for the diagnosis of MS, what they're proposing is that perhaps all MS patients need an aquaporin 4 and a MOG antibody test in order to accurately make the diagnosis of MS. This is something that is not widely accepted, but it is an intriguing challenge to MS clinicians. In the next 3 studies listed here, we want to highlight some of the differences between NMO and MS. Again, the most specific way to do this is with the aquaporin 4 antibody tests. Those who test positive are almost certainly NMO and not MS. But in those who test negative or where the test is not available or early on in the diagnosis before the test is even sent, there are other measures that may be different between MS and NMO. One of these relates to brain volume, specifically in the hippocampus. This one group looked at brain volume and found that it decreases over time in MS patients, which is a known phenomenon, but it does not change over time with NMO. And that's thought to be related to the fact that NMO is not a progressive degenerative process like MS might be, but rather is NMO is more related to attacks and damage from those attacks rather than a progressive neurological disease. The second study uses optical coherence tomography to compare the shape of the fovea that's visualized on the OCT cross-section and compares those between MS and NMO. And what they found is that the shape is actually different. And so here is a cross-section of the fovea highlighted by the arrow. And what this group did is they used a mathematical three-dimensional representation to actually compare the shapes of that fovea, and they found a difference that might be useful and if applied to software machines that are analyzing the OCT data. Then the third study looked at serum biomarkers, specifically GFAP, glial fibrillary acidic protein, as well as neurofilament light chain. These are markers that are elevated during NMO relapses, but what this group found is that these markers also tend to change with age, and so they need to be standardized, at least in the NMO patient population, maybe not in the MS population. And there are other abstracts that were submitted to the AAN, specifically from Viela Bio that conducted the inebilizumab trial, that also looked at neurofilament light chain and found that it goes up with relapses. But exactly how to define those reference ranges are going to be critical and might be different between MS and NMO. Okay, the next series of abstracts relates to clinical trials that were conducted over the past 3-4 years in the NMO patient population. They were all published in 2019 and were all previously presented. And these abstracts represent post hoc analyses. There are 4 for the eculizumab trial, also known as the PREVENT study. And just to refresh your memory of the PREVENT study shown here, there were 143 patients that were randomized 2-to-1 to eculizumab or placebo. They found that eculizumab reduced the relapse risk compared to placebo by 94%, and they provided 4 additional post hoc studies related to that trial, and these are the first 2 here. They're related to quality of life. So in this first study, what they found is that patients who did not relapse had really no change in their quality of life as measured by the EQ-5D or the SF-36 surveys. And that's to be expected. If an NMO patient is not relapsing, they're technically in remission. We don't expect much change in their life or their quality of life at that time. Among those who did relapse, though, there was a worsening of their quality of life as measured by both the EQ-5D and SF-36. And I think that's no surprise. When you relapse, you lose neurological function, you gain pain. There are lots of other measures in the quality of life scores that got worse, including domains related to physical functioning and emotional functioning. And so again, this is not a surprise that patients who relapse lose quality of life. In that second study, again, also related to the PREVENT study, they found that if you prevent relapses, in this case with eculizumab, you can prevent worsening of the quality of life in both the EQ-5D and SF-36. So preventing relapses prevents worsening of quality of life. In the third post hoc analysis that was submitted related to the PREVENT study, there was always a question of whether or not rituximab prior use or prior enrollment into the trial contributed to the outcome of the study. What this study looked at is, of all the patients who were on rituximab in the past, what were their safety and efficacy outcomes? In the placebo arm, there were 20 patients out of the 47 who had used rituximab in the past. The average time of enrollment was 6 months after last rituximab infusion. The rules required that patients be at least 3 months, but on average it ended up being about 6. And in the placebo arm, 20 of those patients who were enrolled in the placebo arm were on rituximab in the past, of which 7 relapsed. Now 7 out of 20 is 35%. If you compare that to the average relapse rate of 43% in the entire placebo arm, maybe there was an effect of rituximab in preventing relapses, but mostly we think of rituximab as wearing off after 6 months, so any benefit would have been short-lived. In the eculizumab arm, there were 26 out of the 96 patients who were on rituximab in the past, again an average of 6 months prior, of which 1 relapsed. There were 3 relapses total in the eculizumab arm, of which 1 was on rituximab in the past. I don't think there's anything contributory provided by rituximab in this arm either. And on the safety side, when you look at the risk of adverse events as a whole, about 43% had an adverse event in the placebo arm. Of those who were on rituximab in the placebo arm, the adverse event rate was 47%, not that different. And in the eculizumab arm, adverse event rate was 38% among those who were on rituximab in the past. Again, there's not much difference there, so we don't think that rituximab really contributed to the benefit seen in the eculizumab trial or any additional risk. In the final study of the post-hoc analysis related to the PREVENT trial, the sponsor provided data on the extension phase. So there was a 2-year trial. Initially, that was the one that was published, and that's what the drug got their approval on. But then there was a 2-year open label phase into which most patients were rolled over either because of a perceived relapse by the site PI, or after 2 years they were all rolled over into the open label phase. And in the initial experimental phase, there were 3 patients on eculizumab who relapsed. In the open label phase, there were an additional 5 relapses, so a total of 8 relapses. And what's not provided in the abstract is anything about the characteristics of those 5 additional relapses. We don't know if they were optic neuritis, transverse myelitis. We don't know if they were mild or severe, how well they recovered. All we know is there were 5 more, and so we really needed more information on that. There were no additional safety signals. There were no patients who had an Neisseria meningitis. There was 1 patient with an Neisseria gonorrhea that was treated, and there were no additional deaths. There was 1 death in the experimental phase of the trial, no additional deaths in the open label phase. So those were the 4 post-hoc studies related to the PREVENT trial. Now, the second major phase 3 trial that was published in 2019 used satralizumab, which is an IL-6 receptor monoclonal antibody, blocks IL-6 receptor signaling. There were 2 phase 3 trials worldwide. One was Sakura STAR, which was a placebo monotherapy, and one was Sakura SKY, which allowed background therapy. And in this post-hoc analysis, all they did was they combined the treatment data from both trials in order to see if there were any safety signals that emerged from the larger patient group. There were 104 total exposed to satralizumab, 74 in the placebo. And the only real difference between those 2 arms is injection-related reactions, which were minor in most circumstances, did not result in any withdrawals. And then basically all the adverse events after that, beyond infusion or injection-related reactions, were equal between the 2 arms. And so there were no new safety signals that emerged from this analysis. Now, tocilizumab is the parent compound for satralizumab, and in this study, what was done is a retrospective review of NMO patients who were using tocilizumab, but with the subcutaneous formulation. So the 2 previous studies used IV formulation, and then we had the satralizumab trial, which is sub-Q. Tocilizumab, the parent compound, also has a sub-Q formulation, known in the US as Actemra, and we had some patients on Actemra already, and so this was really just a retrospective review of those patients who were already on Actemra and what their outcome was. It was 2 centers in New York and Baltimore, 13 patients total, not a large sample size. When you look at their annualized relapse rate prior to starting tocilizumab, the relapse rate was 2.2. After starting tocilizumab, the relapse rate was 0.6. And so this reduction in the relapse rate was common among the IV studies as well, and was not that different from the satralizumab trial. So the authors concluded that subcutaneous tocilizumab is basically the same as IV tocilizumab in terms of prevention of relapses in NMO, and there were no additional safety concerns here as well. The third phase 3 trial that launched in the NMO space was inebilizumab. That is a CD19 monoclonal antibody that depletes B cells a few more plasmablasts and pro-B cells compared to rituximab, but basically a B-cell depleting drug. They enrolled 230 patients in their experimental phase of the trial, and that was published in the Lancet in 2019. This post-hoc analysis looked at the extension phase of that trial. In the original trial, there was a reduction of relapse risk by 77% compared to placebo among patients who were aquaporin 4 seropositive. In the extension phase, the efficacy was about the same. So there was an 84% rate of remission among those in the extension phase. And if you look at the experimental phase, there was about an 88% rate of remission. So fairly similar in the open label phase. And there were no new safety signals that emerged. The adverse events were fairly similar between the open label phase and the experimental phase. So those were the three main drugs that are in development. They will probably all get FDA approved. Eculizumab has already been FDA approved. There are some additional treatment options that are being developed. One intriguing abstract that we want to call your attention to is using cladribine. Cladribine is an analog of adenosine, the ATGC of DNA. And once inside the cell, it contributes to the cell's death, most notably of lymphocytes. It's being used to treat all kinds of cancers, as well as autoimmune disease and multiple sclerosis. In this case, it's being used to prevent relapses in neuromyelitis optica. This was a 2-year study. It only included 11 patients at one site. It was given as a subcutaneous formulation. Prior to initiation of treatment, the relapse rate was 1 in this patient population. After treatment, the relapse rate was 0.23. So out of the 11 patients, 4 relapsed. Those are not great numbers in light of the 3 trials that have been published, but there are no major safety issues. We have years of safety data from cladribine in general and experience using it in the MS population, and it might be useful in the NMO patient population that are intractable to other treatments. The last abstract that we'd like to present is interesting in that it uses Facebook to recruit patients. This was a study that polled patients on an NMO group in Facebook, a private NMO group, and within a week it recruited 206 patients, of which more than 2/3 were aquaporin 4 seropositive, self-reported, and 87% were female. These are numbers that are relatively the same as the general NMO patient population, so we think it's a good reflection of the NMO patient population. And in this group, 71% reported having some kind of paroxysmal spasm. It lasts at least 2 minutes. And these spasms are associated with tingling, numbness, and other sensory findings, as well as involuntary muscle contractions. Now, these paroxysmal spasms are aggravated by fatigue and physical activity. These are not surprising. What was surprising is that more than half reported no improvement with drugs like gabapentin that they were using, or carbamazepine. So this is an unmet need that needs to be addressed. Now, future studies that use social media need to be able to verify the information coming in, for example, aquaporin 4 antibody testing, but it's a great way to reach out to many more patients, especially for rare diseases like neuromyelitis optica. So in summary, NMO is a very rare autoimmune disorder, targets the aquaporin 4 water channel. The symptoms do vary. They are similar to MS. They have lots of optic neuritis, like MS, as well as transverse myelitis, but it is distinguishable with the aquaporin 4 antibody test. There are treatments that are available now for NMO and that are important to distinguish from treatments that are used for MS that might be harmful in NMO. We're hopeful that the AAN will provide some additional data in online presentations from the 2020 conference. Thank you for your attention.